Hey everyone, I'm Dr. Kendall Wyatt. Welcome back. Let's move on to our next topic. Today, Stitch and I are going to be doing a rapid review of diabetes medicines. Right, Stitch? Let's get started. I'm Dr. Kendall Wyatt. Today, we're going to be doing diabetes medicines. Now, this is a rapid review of diabetes medicines. If you want to see all the nitty-gritty details and more details on mechanism of action, then you should probably check out each individual drug because that's where all of the what I call boring stuff. Now, if you're into rapid reviews, one thing you should check out is Picmonic. If you've never used Picmonic, what they do is take all of the things you need to know in nursing or medicine and turn them into fun characters. So if you're learning warfarin, you can learn the war fairy, and you can just learn that little war fairy right there. But you also need to remember the opposites, like heparin, and you can remember the hippie heron. So you can check it out at picmonic.com for free. And of course, if you go to picmonic.com/WyattMD, that has a nice ring to it, right? You can check it out for free. So you can use Picmonic to help you remember all the difficult facts, all those nitty-gritty details of which one's up, which one's down, which one's increased, which one's decreased, and all of those things in between. Each particular topic takes about 2 minutes. So if you don't want to listen to me yammer on, then go to picmonic.com/WyattMD and you can get 20% off for checking it out. Of course, you can always try it for free. Now, what are we covering today? Today, we're doing rapid review of 7 different classes of diabetes medicines. We're going over the biguanides, sulfonylureas, the second generation ones, meglitinides, the GLP-1 analogs, the DPP-4 inhibitors, the SGLT2 inhibitors, and those, thiazolidinediones, TZDs for short. I'm never going to re-record that and try to get it right. I'm not even going to try. Before we get started with that first medicine, one thing I want you to see is the format of what we're going over today. We're going to go over the drug classes and an ending if they have one, and of course the names of all the drugs because you need to remember those. We've got a few shortcuts for you to help remember those as well. The mechanism of action for each one, today we're doing detailed generalized things. So really just what the mechanism of action is. You'll see some snippets and flashes on the screen of what we go into detail in our other video, but everything you need to know really is in this one at a rapid pace. We'll go over the highest yield side effects and some explanations on those, whether they make you gain or lose weight, and of course the most important points and teaching points you need to know for your patients and for your exams. What they're contraindicated for, which are pretty much also really important side effects, and of course when we use them. And for funsies, I threw in when they're used first and about how much they cost as well as the route. Now let's get started with our first drug class. It's essentially one medicine, the biguanides, or metformin. Now there's no drug ending here because you just need to remember metformin. Now for metformin, you can remember our Picmonic character, the meat farmer, and go check it out at Picmonic. Now, as we talk about the mechanism of action of metformin, really, there's a lot of different mechanisms of action. There's a lot of nitty-gritty details in here that, to be honest, you just need to have the general idea. Now, metformin is a great medicine. It's been around for a long time, and lots of patients take it. But what does it do? Well, it does a lot of things. It decreases hepatic glucose production, increases insulin sensitivity, and decreases the intestinal glucose absorption. So, from there, it's kind of a triple whammy. Of course, there's a few other whammies in there as well. Now, I'm going to show you just a quick preview of what the mechanism of action is, and I'm not going to go over this in detail. But what you need to know is the mechanism of action essentially works in the GI tract, the liver, the pancreas, the adipose tissue, and the skeletal muscle, as well as some effects in the systemic circulation for inflammation. Now, here's the mechanism of action. Again, a busy slide, lots of different things on here. But remember, you've got the GI tract, the liver, the pancreas, the adipose tissue, and the skeletal muscle. So for more detail of walking through this, you can check out the other video because honestly, it's pretty boring. It's a lot of different details of things that may or may not be relevant to what you're learning right now. When we talk about each particular one, here's the simplified form again. Decreased intestinal glucose absorption, of course, is in the GI tract. And then we've got our decreased hepatic glucose production, which is all in the liver. And that's where the main mechanism of action of metformin is. And it really works with this thing called AMPK, which shoots out and has a lot of different effects everywhere else. And of course, in the adipose tissue and the skeletal muscle, it increases insulin sensitivity. So what's a big problem with diabetes? Well, decreased sensitivity to insulin, right? Now let's move on to the rest of metformin, all the other details you need to know. When we talk about the high-yield side effects, these are really important, and you've really got to know these down cold. So the number one is diarrhea. Metformin classically causes almost everyone who starts it some diarrhea. Not really fun for people to maintain compliance. But one thing that is interesting is often the diarrhea subsides over time. Another important thing is sometimes you can give people the long-acting form, which won't cause as much GI side effects. But tell them, hold on, it'll work because the medicine is worth it. The other thing is lactic acidosis. Now, lactic acidosis is important because one, it's deadly. But the other thing is it works with the mechanism of action. So if you remember that metformin decreases hepatic glucose production and increases insulin sensitivity, well, one of the ways it does that is shunting something called pyruvate into lactate. Well, lactate causes lactic acidosis. So normally your body and your skeletal muscles and everything can break this down and turn lactate into energy. However, when you're dehydrated, you're not doing so hot, you're sick, or this extra lactate can increase and cause lactic acidosis. And of course, it can complicate lots of different things. So just remember that lactic acidosis as a big, important, very commonly tested side effect. Now, the last thing, I see it tested a lot, but it's more theoretical more than anything, is B12 deficiency. Remember that B12 deficiency does not develop fast, so it takes a long time, years to develop B12 deficiency, so not something that's going to show up really right away. Now, if we remember that mechanism of action, remember that metformin works with GLP-1 to decrease glucose absorption in the GI tract. Well, you can also remember that metformin often may cause patients weight loss. Now, technically, it's classified as a weight-neutral drug, but with that mechanism in the GI tract, it can actually cause some weight loss. Now, the one really important point you must know for metformin is that you've got to stop metformin before any kind of IV contrast dye. Well, why is that? Well, remember, what's that side effect? Lactic acidosis. Well, when you give IVP dye, what IVP dye does is it's pretty hard on the kidneys. So if you beat up the kidneys and you can't really excrete and get rid of all the lactate, then what happens is you can increase and cause lactic acidosis as well as renal failure, and that's why we stop metformin 3 to 5 days, ideally, before giving contrast dye. Yes, I know, Linda, that everyone you see in that one time you're in rotation comes in on metformin in the ER and they still get the contrasted study. And that's because the benefit outweighs the risk. So you just give patients hydration to keep them well hydrated and not damage those kidneys. Now, remember that IVP dye causes kidney problems, which causes a buildup of metformin, which could lead to lactic acidosis. Well, then you can tie that right in as well because metformin is actually contraindicated in complete renal failure. And again, because it builds up to toxic levels and can cause lactic acidosis. So it's contraindicated below a creatinine clearance less than 30. And it needs to be dose adjusted for those people with renal failure. Don't forget that. That's important. But you can tie those points together and really remember everything about metformin. Really simple. Easy peasy. Metformin's a first-line medication. We use it first because it's cheap. It's $4 to $10 a month, and everyone should be on it. If you are a diabetic, I don't care how much it makes you poop, you should take it. Because if you poop a lot, then you lose weight, right? Yeah, of course. Don't forget about that dehydration and lactic acidosis, though. And of course, it's an oral medicine, usually taken twice a day, but there's a long-acting form that's available. Let's move on to the next medicine. Now, next, I want to talk about second-generation sulfonylureas. Now, the second-generation one, because the first generation, nobody cares about the first gen. We're all about the second gen now. These medicines don't really have a drug ending either, but you can remember glyburide, glipizide, and glimepiride. Now, I remember our little Picmonic characters, Guy-bride and glipizide, our Grizzly Guy-bride, because that's just how I remembered it. Now, how does second-generation sulfonylureas work? Well, they increase insulin release. They directly stimulate those pancreatic beta cells to release insulin. Okay. Now, I'm going to go over just a quick demo of exactly how this works, and I'm not going to go into the detail. If you want detail and you want to know all this stuff, well, good for you. You could check out the more detailed video. Just remember, it inhibits potassium channels and causes release of insulin from those pancreatic beta cells. That's the part you got to know. So what else do you need to know for second-generation sulfonylureas? Well, there's a few important points. These medicines aren't very nice, and we don't use them right away. They're not something you want to use first. They increase insulin release. Remember those pancreatic beta cells, so directly stimulate a release of insulin. So, a direct stimulation of a release of insulin will lead to hypoglycemia. These medicines cause hypoglycemia, and sometimes really severe hypoglycemia. The medicines are pretty long-acting, so they last a while, so you can have pretty severe hypoglycemia, sometimes requiring hospitalization. These medicines are very classic to cause something called a disulfiram-like reaction. Well, what does that mean? Well, disulfiram is actually a medicine antabuse. We give it to patients who drink alcohol or who have alcohol issues. So when they drink alcohol with antabuse, it causes them to feel very nauseated and they vomit. So sometimes people who take second-generation sulfonylureas and drink a little alcohol can end up with a disulfiram-like reaction, causing severe nausea, vomiting, and GI distress. Another just kind of random fact, but it's commonly tested, is that they can cause a hemolytic anemia. Now, these are only in patients with something called G6PD deficiency. If you don't know what that is, that's fine. I'm not going to go into it today. But what happens is it can cause a hemolytic anemia, a breakdown of red blood cells in those patients. Now, this medicine causes weight gain. You can remember that it causes weight gain because it increases insulin. If you take insulin, insulin causes weight gain. Well, that's just a side effect. So these increase insulin, so they're naturally going to also cause weight gain. Now, there's some important points overall with second-generation sulfonylureas, glyburide, glipizide, and glimepiride. Some of them have shown for increased risk of cardiovascular mortality for patients who are taking them, especially patients who are elderly. We don't use these medicines in elderly patients, and they're not recommended, mainly because of the side effects, hypoglycemia, as well as an increased risk. They also are used with caution in patients with renal failure. And that's because they're excreted through the kidneys, and if you don't have very good kidneys, guess what happens to the levels of these medicines? They go up in the body. And what's the big side effect of these medicines? Hypoglycemia. So if you have a lot of a medicine that causes hypoglycemia, well, you just need to basically continuously drink Pepsi or Coke, whatever you're into. I'm kidding. But we don't really use these medicines that often. They're actually indicated third line, so you don't want to use these right away. They're cheap medicines, however, so they only cost $10, $15 a month. One of them is a little bit more, but $10 to $15 a month, and they're taken by mouth. So a lot of patients want these medicines and ask for these medicines, but this is not what's indicated and not what's best for the patient. That's it for second-generation sulfonylureas. Let's take a look at the next drug class. The next drug class I want to talk about are the meglitinides. Now, these medicines kind of end in glinide, and I know I cheat a lot on these drug endings because they're not really across the board. But that's because if you're just remembering the diabetes medicines, it really kind of helps have those little endings. This includes nataglinide, repaglinide, meglitinides, and what's important about these medicines, you can remember our little wrapping grenade and our knitting grenade to help you remember from the Picmonic characters. But what's the mechanism of action? Well, just remember that these medicines increase insulin release. So we just learned the second-generation sulfonylureas. You remember that those are long-acting, big risk of hypoglycemia. Well, these medicines are pretty much the same. They actually work in the pancreatic beta cells the same way, with that inhibiting the potassium channel to cause insulin release from those pancreatic beta cells. They work with a little bit different route, but exactly the same way. So you want to learn that detailed mechanism of action, you check out the other video because it's kind of boring here. But what's important is it increases insulin release. So you're going to end up with hypoglycemia. But what's important is that these medicines are short-acting. They're short-acting medicines. So you want to take them before every single meal, which is essentially why these medicines came out and are better, because they're short-acting medicines. They don't last as long, and they work with a little bit different mechanism of action. Now, these medicines, of course, can cause hypoglycemia, and I know I got a little out of order here, but they can cause upper respiratory tract infections. You're going to see this on a lot of different medicines, and I don't put it on every single one, but especially the diabetes medicines. And it's because there's a theory that it generally decreases the effectiveness of your immune system just a smidgen. And what happens is you're more susceptible to these not so severe upper respiratory tract symptoms and infections. But with these medicines, just remember, you want to use caution in liver failure or renal failure, depending on which one you're using because of how they're excreted, because they're going to increase the levels of those and, of course, that side effect of hypoglycemia. These medicines are also used second line, and they cost about $100 a month, so they're not the cheapest, but they are just a smidgen better than those second-generation sulfonylureas. For a pill, that is. Let's take a look at our next drug class that we're going to talk about. The next drug class I want to talk about are the GLP-1 analogs. Now, this medication class is something to be excited about because they're new, and everyone loves new things, right? Well, newish, okay. But there's some new drugs coming out in the class. We'll talk about that in a sec. So you can remember the GLP-1 analogs with the ending tide. Now, tide, you can remember that inside of diabetic drugs to help you remember all the diabetic drugs because there's a lot of the medicines there, right? Zenitide, liraglutide, dulaglutide, and my little asterisk friend, semaglutide, which is a new one that's in phase 3 trials coming out. Talk about that in a second. So how do these medicines work? Well, they're incretin mimetics. What is that? When we talk about this mechanism of action for GLP-1 analogs, I'm not going to go into great detail here, but they work in the GI tract and the pancreas. And they work with something called GLP-1, so they're this incretin mimetic. Just remember that what happens is GLP-1 actually decreases the alpha cells, so decreased glucagon, and it increases the activity of the beta cells, which leads to increased insulin. So you end up with less glucagon and more insulin released from the pancreas. So if you remember that these particular medicines, they go to the pancreas and they stimulate the alpha cells and beta cells to increase insulin and decrease glucagon, well, that's a lot of action in the pancreas. And if you have that, you have the side effect that can happen. You really got to know the important side effect of pancreatitis. So you can remember Zenitide with our little Xn sign here and our GLP-1 analogs with our big GLP cup with a 1-1. Other side effects, and I feel like, again, kind of going with every single drug, but you can have GI upset. I don't know what drug label out there doesn't say may cause nausea, vomiting, diarrhea, constipation, headache. It's a pretty common side effect in some people for some drugs. But these can cause GI upset, again, because they work with the GI tract. Now, because these medicines also increase insulin and decrease glucagon, you can have hypoglycemia. Not so much independently by themselves, but definitely something you need to know about. And by remembering the mechanism of action of how they work, the general idea, it's really easy to think through the side effects as well. Now, these medicines actually can cause weight loss, and that's a really important thing to know because of how they work and their new mechanism, GLP-1 and GIP, gastric inhibitory peptide. But GLP-1 can increase your satiety. So, you feel full and you don't eat as much, and that's why they cause that weight loss benefit. Now, with this, some important points you've got to know, because there's several of them for these class of medicines. You have an increased risk of something called C-cell thyroid tumors, or thyroid C-cell tumors. This is specific in patients with something called MEN2 syndrome, multiple endocrine neoplasia type 2. MEN2 is not as important to talk about today, but just remember in general that they can cause thyroid tumors. It's not something that everybody's going to get, but it's just something to be aware of in those types of patients. Wouldn't give it to somebody with MEN2 because they're at high risk for those already. Also with these medicines, they can be usually given before meals. Now there's some long-acting forms of these, and they can be given that aren't given every single day, that are now be given once a week, twice a week, and there's a few different formulations depending on the brand that they're coming out with. It's also important to remember, because I like to mention this is the only one that's studied at this particular scale, but liraglutide actually shows some cardiovascular benefit. And whether that's because of the weight loss properties or whatnot, to be honest, I can't remember right off. But just remember that liraglutide can end up with some cardiovascular benefit to many patients. So it's good for those types of patients. Creatinine clearance, some of them are contraindicated for Zenitide, for example, because it's excreted that way, and you don't want those toxic levels. These medicines are second line. Now, they're second line, in my opinion, because they don't bring down the A1C or your glucose levels a whole bunch all by themselves. They need to be with something like metformin, but also because they're expensive. These medicines are almost $1,000 a month. That's a lot of money for a medicine. But remember that these medicines are also given sub-Q, so the patients may not want it. If they're a patient who's already avoiding insulin, they don't want to be on insulin, they're probably not going to want to be on these medicines either. And if you remember semaglutide, the little asterisk that I put up here, well, that's because this medicine, which is in phase 3 trials and will be going to market, is actually an oral formulation of a GLP-1 analog. So just remember that one, because that'll be exciting once it goes on the market and patients start taking it and we see how it does. Let's move on to the next drug class we're going to talk about with our diabetes medicines. So now let's talk about the DPP-4 inhibitors. This class of medication actually does have a great drug ending. It's called gliptin, and you can easily remember all the drugs by remembering the gliptin. Now, with these, you can remember gliptin could be Griffin. So for our Picmonic characters, you can remember sitagliptin and saxagliptin by our star sitar Griffin and our saxophone-playing Griffin. You can go check those out yourself. So with these medicines, also linagliptin, remember that they increase insulin release as a mechanism of action. So DPP-4 inhibitors are dipeptidyl peptidase inhibitors, which prevent you from breaking down something called GLP-1, that enzyme. Remember, that's the same enzyme that works with our GLP-1 analogs, right? GLP-1 analogs actually increase GLP, and then DPP-4 inhibitors prevent the breakdown of GLP. So what happens? Lots more GLP-1. Now, I'm not going to go into great detail on this mechanism of action, but you can see here again, it works the same mechanism of action here. So you end up with less glucagon and more insulin, because our GLP-1 analogs work right here to actually stimulate GLP-1, and our DPP-4 inhibitors prevent GLP-1 from being broken down. Now, with these medicines, you've got to know some high-yield side effects, because there's a bunch of them for these. Well, there's upper respiratory tract infection-like symptoms. Yes, it's there. But because these medicines work on the same mechanism that really stimulate the pancreas to increase insulin and decrease glucagon, works on alpha and beta cells, you can lead to pancreatitis. So remember that. That's really important. The one thing that's also a black box warning now is you can actually cause something called bullous pemphigoid. What's bullous pemphigoid? Well, bullous, bulli, big giant bulla, or raised bubbles on the skin, right? And it can actually happen throughout the whole body. So you can have a systemic reaction in some patients, but just make sure you remember. Our DPP-4 inhibitors have an important point to remember, that it can increase your risk of CHF, congestive heart failure. These medicines are renally dosed, so you don't give them in severe renal failure. And they're a little bit cheaper than the GLP-1 analogs, but still pretty pricey. About $450 a month. The good thing about these is that they're oral. So it's a pill that you can take, and these patients can take it. So you can add it on to the other medicines and take this as well. Let's talk about our next drug class that we are going to go through today. So this drug class are the SGLT2 inhibitors. I really like these, mainly because I like to say SGLT2 inhibitor 5 times fast. So this class of medicines, the SGLT2 inhibitors, you can remember because of the drug ending flozin. Canagliflozin and pagliflozin, you can remember those. And there's a few others out there that I can't remember the names of. But what's important to know is they end in the drug ending flozin. So I just remember flozin because of flowing urine, and we're going to get to that in a second. It's going to make a lot more sense. Because what's the mechanism of action of these medicines? Well, they reduce the filtered glucose absorption in the proximal tubule of the nephron, right? So in the nephron, nephrons are in the kidney, kidneys make urine, flows in. Just remember the flows in. Just remember. Yeah, it makes sense, I know. So I'm not going to go into great detail on the mechanism of action, but just remember, in the proximal tubule of the nephrons inside the kidney, they reduce the filtered glucose reabsorption. So if you don't reabsorb as much glucose, and you pee it out. There are quite a few high-yield side effects you've got to know and things with the SGLT2 inhibitors. Number one is that you can have diabetic ketoacidosis, and more importantly, it's euglycemic diabetic ketoacidosis. So you're not going to have an elevated glucose, but you're going to end up with ketones and acidosis. Really important because it's probably more commonly missed than we think, because the blood sugar, when the blood sugar is 600, you probably always check them for ketoacidosis. But it can happen without the glucose going high. And again, it's because of the mechanism of action, how these medicines work. Another thing with these is they can cause urinary tract infections. And I think this is easy to remember. When I think about the flows in of those SGLT2 inhibitors, flows in, flow in urine, just remember. And if you're flowing urine and it's got a bunch of glucose in it because you're peeing it out, where does bacteria love to live? It loves to live in sugar. Loves it. And when it lives in that sugar, you're going to have a higher increase for bacteria to grow and have urinary tract infections, as well as yeast infections. Yeast loves sugar. What do we make beer with? Sugar, yeast, right? Just remember that, yeast infections. It's really, really common, and we see it a lot in patients. Now, two of the ones that you don't really think about a lot is that SGLT2 inhibitors can cause orthostatic hypotension. So, blood pressure when you stand up, blood pressure drops, pulse goes up, and you could pass out, maybe. But the reason also for this is because these medicines increase glucose in the urine, they make you pee more, and you could become more dehydrated. So if you dehydrate easily, these medicines could more likely cause orthostatic hypotension. The last one is Fournier's gangrene. Now this is a big warning. I've seen a lot in the news recently about these types of medicines causing this. And again, if you're having a lot of urine down there and the urine's really sugary, what happens with urine that might leak between the legs and have a bunch of sugar in it? Bacteria and the nasty stuff grows, right? Yeah, I know, I can't help it. But all of that then leads to something called Fournier's gangrene, which is very serious. So it's a gangrene, it's an infection in the groin area, and it's very serious and very life-threatening. It needs surgical intervention. So just remember that all this sugar, peeing out all this sugar, maybe not the best thing in all cases, but it really does work as a medicine and effective. This medicine causes weight loss, can cause weight loss in many patients, as well as provide some cardiovascular benefit, as some of the medicines have shown in some studies. Now, remember the mechanism. It works in the proximal tubule to make you pee out more glucose. So naturally, it's contraindicated in somebody whose kidneys don't work. I think that makes sense, but some people, they work so hard trying to memorize all this stuff and just don't think through it. Don't forget that. There's second-line medicine because they're second-line, metformin's first, and they cost about $500 a month. The good thing with these is that it's a pill, so it's a medicine you can take by mouth to add on to help just pee out some glucose. And if you think about all the mechanisms, you have metformin, which you can take to have your liver work better, the fat tissue to increase insulin sensitivity. You've got the sulfonylureas to increase insulin release, the meglitinides to increase insulin release. You've got the GLP-1 analogs to increase GLP, to increase insulin, decrease glucagon, and the DPP-4 inhibitors, which do the exact same, and of course the SGLT2 inhibitors to just make you pee out the rest. Of course, you wouldn't take them all, but a good combination would work for many patients. Let's take a look at the last medicine that we're going to talk about, medicine class for diabetes. The last class of medicine are the thiazolidinones. That's all I got. I'm never going to get it right. I give up. I always just call these the TZDs, the glitazones. Now, the glitazones, they end in glitazone, and this is probably one of my favorite Picmonic characters, Pug glitazone, for pioglitazone. So pioglitazone is our little pug glitazone. You can check out the Picmonic to help you remember the drug class, and all the things. But if you can just remember pug glitazone for pioglitazone, you're going to get it. And it'll help you remember that these are the TZDs. So pioglitazone, rosiglitazone, what's important? How do these work? Well, they increase insulin sensitivity, and they bind something called PPAR gamma. Again, I'm not going to go into great detail on the mechanism of action, but they increase the insulin sensitivity, and they work outside in all of the tissues, in the skeletal muscle. So if you think about this, there's some high-yield side effects you need to know. TZDs don't come without their side effects. They can cause hypoglycemia. You've got to remember TZDs because they increase the risk of congestive heart failure. They're actually contraindicated in New York Heart Association Class 3 and 4. And if you don't know what New York Heart Association Class 3 and 4 is, just remember that these are people who aren't active and able to walk without becoming very short of breath and aren't able to do their activities of daily living. So if they have a later stage or more advanced heart failure, absolutely don't give it to them. And also remember that it can cause congestive heart failure or exacerbate congestive heart failure. And that's why we remember this side effect of edema. These medicines can also cause liver failure. They're metabolized by the liver, and they can cause weight gain. Some other really important side effects, gotta remember there's several of them if you were to look at the black box warnings, is especially rosiglitazone, you have an increased fracture risk. But also, all of them have an increased bladder cancer risk. And this is just in general. Just remember that TZDs have an increased risk of bladder cancer for all patients. So if they're already at increased risk, maybe don't add in another medicine that could increase the risk. So you may choose a different medicine. These medicines are also indicated second line, and we don't really use them routinely that often anymore. Because what we find, especially, is we see a diabetic with hypertension who leads to congestive heart failure, especially if they're not caught early. So this medicine doesn't always jive with a lot of the comorbidities that we see in severe diabetics. They're relatively inexpensive, $20 to $100 depending on which one and where you're at, and it's a pill that you can take. Just make sure that these medicines, people know the side effects, and you know those for your exams. And that's it for the TZDs. So now if I was just going to quickly review all of these together so you can kind of just think through what's going on. The biguanides, metformin. Remember lactic acidosis? Don't give with the IVP dye, contrast dye, right? Second generation sulfonylureas, well, second gen, they're third line. And remember that these medicines cause severe hypoglycemia and are really long acting. Now, the maglitinides, they're shorter acting than the sulfonylureas. They work with the same mechanism pathway, and of course, cause hypoglycemia. But you got to take them every time you eat. The GLP-1 analogs, okay, great med, and increases insulin and decreases glucagon with the GLP-1 enzyme. And of course, that's the same mechanism, just a little bit different pathway because of preventing the breakdown of GLP-1 of the DPP-4 inhibitors. Both of these medicines cause pancreatitis, and it's again because of the way they work. The SGLT2 inhibitors, those flozins, remember that's the one at the end. I put it at the end of the line because you pee it all out. Pee out the sugar, and don't remember, when you're peeing out a lot of sugar, you've got urinary tract infections, you've got yeast infections, Fournier's gangrene, and all of those things. The TZDs, never going to pronounce the name. Just remember CHF risk, bladder cancer risk, and pretty much not going to use it. So that's it. That's all we've got for our rapid review of our diabetic medicines. You can check out the other videos, but you can also check out Picmonic. So if you had trouble following today or you wanted to just rapid review all the facts, you can go check out Picmonic for free, but for 20% off discount your order, you can go to picmonic.com/WyattMD. Thanks for joining today. Today's video was a rapid review. If you want to go over the details, a little bit more mechanism of action, watch for our mechanism of action videos going over, honestly, all the boring stuff. Check out the other videos below and then click subscribe. I never know which way to look. And we'll see you at the next video. That's all I've got today. I'm Dr. Kendall Wyatt. We'll see you next time.